Hello everyone, I am Nancy Joji Varghese, student of Saint Scholastica. Today I am going to give a presentation about the effectiveness of pharmacological and non-pharmacological interventions for chronic low back pain. As you all know, chronic low back pain has different causes. Usually, chronic low back pain is the pain that starts from the lower back region, that is the lumbosacral region, and sacroiliac joint to the leg. Learning objectives: general etiology of chronic low back pain, treatment of chronic low back pain, efficacy of pharmacological and non-pharmacological treatments. In-depth explanation of effective pharmacological intervention in chronic low back pain, and in-depth effectiveness about the non-pharmacological methods to treat chronic low back pain. Develop awareness of taking opioids, non-steroid anti-inflammatory drugs, withdrawal, side effects and benefits, and the dosage for over-the-counter analgesics, lifestyle and behavioral modification. Introduction. About 90% of adults experience low back pain at least once in their life. Low back pain can be defined as pain that occurs at the lower region of the vertebrae lumbar spine, which connects to the pelvis in the sacral region. Classified as acute and chronic low back pain, may be mechanical or may have some other underlying causes. Usually, acute low back pain lasts up to 4 weeks. Pain that lasts more than 12 weeks is chronic low back pain. People in the age group of 50 to 60 are mostly affected by chronic low back pain. Patients get tremendous improvement for chronic low back pain with both non-pharmacological and pharmacological interventions. Etiology of chronic low back pain. According to Writers et.al. 2019, biomechanical causes produce movement, wear and tear. Degenerative diseases also cause chronic low back pain, and I have shown a picture here of a degenerative disc. Foraminal stenosis, spinal stenosis and vertebrogenic pain, osteoarthritis, facet joint pain, myofascial pain, sacroiliac joint pain and discogenic pain. Neurologic causes such as sciatica and bladder related causes, inflammatory causes, example sacroiliitis, sedentary lifestyle, cancer related low back pain, back injuries such as car accidents and falls from stairs, overloaded physical activities, and obesity. Lumbar region holds full body weight, so the stress induced damage to the lumbar region. Here is one picture I have shown. The pain occurs in the region of lumbar and the lower back when the subject affected with sciatica. Next is the treatment, pharmacological and non-pharmacological interventions. What are the pharmacological interventions the physicians usually providing to their clients to reduce the pain and subside the inflammation? Here is some medications usually they prescribe to the patients. Acetaminophen, non-steroid anti-inflammatory drugs, topical analgesics, muscle relaxants, opioids, corticosteroids, antidepressants, and anticonvulsants. Acetaminophen. Generic name is acetaminophen and brand name is Tylenol in USA and paracetamol in UK. Mechanism of action: acts on central nervous system and inhibit prostaglandins and inhibits cyclooxygenase. Indications: analgesic, antipyretic, myalgia, viral infections. Pharmacokinetics: it's well absorbed orally. This is the dosage of acetaminophen for adults and pediatrics. Usually that is not in the scope of physical therapy, but we should be aware about the dosage, what our clients or our patients using while they are coming to the physical therapy clinic. Usually mild pain could be reduced by acetaminophen, but there are so many adverse effects of these medicines and are nausea, stomach pain, loss of appetite, itching, rash, dark urine, clay colored stool, swelling in the face and neck and limbs, and liver failure. Non-steroid anti-inflammatory, according to Litchfield, ETAL. 2023. Generic name of ibuprofen is brand name Mortin and generic name naproxen sodium. Brand name is Aleve. Generic name of aspirin, the brand name comes as aspirin and Bayer, Accotrin and Ascriptin. Indications: antipyretic, analgesic, anti-inflammatory. Mechanism of action is inhibit cyclooxygenase isoenzymes, inhibit COX-1 and 2. This slide shows the ibuprofen dose for adults and pediatrics. Another NSAID dose and description on this table, and you can go through this table later on. Non-steroid anti-inflammatory drugs are very useful in chronic low back pain as it reduces the inflammation which occurs in the subject's body. However, there is an adverse effect while taking a non-steroid anti-inflammatory drugs. Those are the cardiovascular risk, gastrointestinal risk, and renal and hepatic risk. Adverse effect of non-steroid anti-inflammatory drugs: cardiovascular, gastrointestinal, renal, and hepatic risk is possible. Pharmacokinetics of NSAIDs It is orally well administered and absorbed from gastrointestinal tract. Rehabilitation considerations according to Psychon et.al.2022 provides analgesia. NSAIDs provides benefit to the therapy section. The focus might be minimal. There is no sedative effect, but there is an analgesic effect. Reduce inflammation and minimal adverse effect. This slide shows the topical agents and muscle relaxants. The percentage and the name of the topical agents. NSAIDs, diclofenac sodium 1.5% topical solution, diclofenac hydroxyethyl pyrrolidine 1.3% patch, and diclofenac sodium gel 1%. And the other part I have written the muscle relaxants generic name and brand name. In this slide, it shows the adverse effect of the topical agents and muscle relaxants. When we use the topical agents, be careful about the burning, crusting, oozing, pain, redness, ulcers, and some contact dermatitis and swelling. Muscle relaxants adverse effects are dizziness, constipation, weight gain, low blood pressure, dry mouth, and heart problems. Now we are discussing about the antidepressants and the anticonvulsants. Antidepressants, serotonin reuptake inhibitor and norepinephrine reuptake inhibitor and tricyclic antidepressants. Indications of the antidepressants are low mood, anxiety, and depression. Anticonvulsants indications are bipolar disorder, personality disorder, mood stabilizers, and neuropathic pain. And there is a link I have given here. You can go through and check the details from that link. Adverse effects of antidepressant and anticonvulsant. Antidepressants increase in anxious behavior, indigestion and stomachache, diarrhea, dizziness, headache, and insomnia. According to Psychon et.al. 2022, rehabilitation considerations are sedation, lethargy, muscle weakness, and also orthostatic hypotension and syncope. During the therapy section, the therapist should be aware of the patient taking antidepressants or anticonvulsants. Adverse effects of anticonvulsants are feeling tired, stomach upset, blurred vision, and dizziness. According to Psychon et.al.2022, rehabilitation considerations are nausea, vomiting, GI disturbance. While during the therapy sections, the therapist should be aware of a patient taking the medicines, anticonvulsants, and the therapy time should be according to their convenience. Indications of opioids and corticosteroids. Opioids indications: acute pain given by low dose and chronic pain. Corticosteroids indications are allergy, asthma exacerbation and COPD exacerbation, anaphylaxis, urticaria, rhinitis, and pneumonitis. Indications of opioid and corticosteroid. Opioids indications are acute pain and chronic pain. Usually acute pain, the low dose should be administered. According to PsychonETAL.2022, rehabilitation considerations are gastrointestinal disturbances, addiction, reduced respiratory rate, hypoxia and hypercapnia, constipation, opioid withdrawal. You always should be carefully attended. Adverse effects of opioids and corticosteroids. Adverse effect of opioids: nausea, vomiting, sedation, constipation, pruritus, dizziness, dry mouth, and fentanyl crisis. Adverse effect of corticosteroids are delayed wound healing, increased appetite, thin skin bruise, mood changes, muscle weakness. Prolotherapy injections. Study article by Agarwal, ET.AL 2023. Prolotherapy injections, natural substances which promote healing response. Example: dextrose, saline, and procaine or lidocaine. Reduce pain in musculoskeletal conditions and diseases or disorders that affect your body, bones, muscles, and connective tissues. Example: arthritis. Side effects of prolotherapy: infection, all at the site of the infection, temporary swelling or pain where the injection occurred, a potential infection with fever and pain, and usually treated with antibiotics. Non-pharmacological interventions: general physical therapy intervention, exercise, massage, stretching, and strengthening, percutaneous electrical nerve stimulation, transcutaneous electrical nerve stimulation, and osteopathic manipulative therapy. While going through all these topics, we have a couple of questions in mind, like how effective the medicines act on chronic low back pain, which medicine is more effective for chronic low back pain, which medicine have less adverse effect, and which medicine is most beneficial. After going through this video and the presentation, I hope you all understand all of this question and its answers very well. Article review. A study of clinical commentary by Anderson and Shahid 2022. Acetaminophen blocks cyclooxygenase pathway in the central nervous system and effective in blocking prostaglandins which produce pain. Acetaminophen changes the descending serotonergic inhibitory pathways. Evidence showed that short-term intake of acetaminophen is safer than long-term, that is more than 12 weeks. Medications for treating low back pain in adults. Anderson and Shahid 2022. Anderson and Shahid studied all the pain medications for chronic low back pain, and the study showed mean difference 1.5 and confidence interval 1.3 on 0 to 100 pain scale. There is no evidence in reducing the pain intensity and time of recovery in taking paracetamol or acetaminophen. Adverse effect of taking acetaminophen showed same in treatment and placebo. paracetamol group 18.7%, placebo group 18.5%, and they concluded that acetaminophen used mostly or give benefit in acute low back pain. Study by Anderson and Shahid on 2022. How effective the non-steroid anti-inflammatory drugs is effective in treating chronic low back pain with an inflammatory component like joint stiffness and tightness. Reduced pain 7 points on a 0 to 100 scale. High quality evidence showed that non-steroid anti-inflammatory drugs were not associated with increased risk of any adverse effects. Relative risk 1.1% and 95% confidence interval may increase the risk for specific adverse events. Odds ratio gastrointestinal 1.80 to 4.22. For heart failure, odds ratio is 1.85 to 2.49. Stroke, odds ratio is 0.97 to 1.18. And myocardial infarction, odds ratio 0 to 0.84 to 2.22. The study of Anderson and Shahid 2022 about opioids used when acetaminophen and NSAIDs did not respond to the patients. Mechanism is blocking the neurotransmitters and give analgesic effects. Moderate quality evidence provide a 10-point reduction in pain on a 0 to 100 point pain scale. Common adverse effects: constipation, nausea, vomiting, headache, dizziness, and dry mouth. Overall higher risk of adverse events compared with placebo. A relative risk 1.3, p value less than 0.01, median rate of adverse effect 49.1%, in placebo 68.9% when opioids take. Combination of analgesics, that is opioids and non-opioids, greater than 15 points on 0.100 pain scale. Confidence interval is 19.3. Shows the risk of persistent use increases with each day of use. Anderson and Shahid 2022 studied about muscle relaxants, benzodiazepine and non-benzodiazepine. Its work for the skeletal muscle and acts as relaxants, muscle relaxants. Muscle relaxants used to treat muscle pain and stiffness in patients with low back pain. Pain relief greater than 15 points for acute, while for chronic it is uncertain. Chronic or short-term antispasmodic have no effect in reducing pain. Taking antispasmodic reduce disability after 3 to 13 weeks of administration. Chronic low back pain increased risk of non-serious adverse effects. The study showed a relative risk of 1.6 and 95% confidence interval. It shows the strength of association between the risk factor and the outcome. Anderson and Shahid 2022 studied about the antibiotics. Antibiotics, how effective it is. Antibiotics are used when there is an infection. A randomized control trial, two groups, and the patients aged 18 to 65 years with a back pain over 6 months with evidence of disc herniation on MRI. Subjects were given a single dose or double dose of placebo or amoxicillin 500 mg per 125 mg used in the first trial. Second trial, they used 750 mg. Mean low back pain reduced in antibiotics groups from 6.5 at baseline to 4.5 at 1 year. And in the placebo group, range of motion 6.3 at baseline to 5.2 at 1 year. Drug-related adverse effects ranged from 56 to 65%. Adverse effects are antimicrobial resistance and Clostridioides difficile infection. Anderson and Shahid 2022 studied about the antidepressants helps in reducing pain, improve mood and or sleep. Analysis shows as selective serotonin norepinephrine reuptake inhibitor more effective than placebo. A reduction in pain 4.33, 95% confidence interval on a 100 to 0 to 100 scale. True effect size. Adverse effect odds ratio is 1.58, 95% confidence interval, and measures the strength of association between the risk factor and the outcome. The summary by Anderson and Shahid 2022 shows only NSAIDs showed benefit when compared to placebo. Like paracetamol, opioids, muscle relaxant, antibiotics and antidepressants, NSAIDs also carry risk of harm in people with comorbidities like kidney disease. Medicines should not be used as the sole treatment method for pain. It should be combined with safe, non-pharmacological strategies such as superficial heat and physical therapies such as exercise, education, and manual therapy. A study of non-steroid anti-inflammatory drugs and gabapentins for chronic low back pain by Miglieroni et.al. 2021. The study design was meta-analysis of many RCTs. Aim was to investigate the efficiency of non-steroid anti-inflammatory drugs and gabapentinoids in chronic low back pain. Included 12 RCTs for this study. Outcomes assessments for the studies effectively conducted shows NSAIDs is effective. Effective non-pharmacological treatments. Here we are discussing couple of non-pharmacological treatments such as TENS, transcutaneous electrical nerve stimulation, corrective exercise gait training, percutaneous electrical nerve stimulation, and osteopathy manipulation. Article review about the non-pharmacological interventions by Eiter et.al. 2023. Conducted a study aiming to evaluate the effectiveness of different types of physical therapy exercises in chronic low back pain. Method of study is randomized control trial. Subjects 37 females aged 18 to 65 with chronic low back pain for at least 3 months. Subjects were randomized using online random allocation software program into 3 groups according to the interventions given. Patients with specific spinal pathology, back or lower extremity surgery were not included. The effectiveness of different exercise groups on core stability, functionality, pain, kinesiophobia, and satisfaction were assessed. Article review Eiter et.al. 2023. Subjects were divided into proprioceptive neuromuscular facilitation exercise group, chronic stability exercise group, and control group. Duration 3 days per week for 6 weeks. Significant gains were seen in the muscle strength and disability scores for both the PNF and core stability groups. Significant decrease was observed in pain and kinesiophobia scores in the core stability group. Core stability exercise group had highest satisfaction. The study by Eiter et al. 2023 assessment was done using the Oswetry low back pain questionnaire for functionality, core stability with a stabilizer, pain intensity and satisfaction with visual analog scale. Conclusion is core stability seems to be beneficial and proprioceptive neuromuscular facilitation showed effective in chronic low back pain. Article review Eiter et al. 2023. The study shows the evaluation was done using the Oswetry Disability Index Low Back Pain Questionnaire and core stability with a stabilizer, pain intensity and satisfaction with visual analog scale. The conclusion of the study showed core stability and PNF treatments are more effective, and the study is statistically analyzed on SPSS and homogeneity of variances found and used students t-test paired and Bonafide correction method used to examine the multiple comparisons. Next is a study by Esima et.al. 2022. Transcutaneous electrical nerve stimulations improve chronic low back pain. The study design was randomized double-blinded study. Subjects 62 and aged 20 to 70 years were included, who had been clinically diagnosed with chronic low back pain resulting from lumbar spondylosis with pain intensity greater than 5 on NPRS. evaluated the responses of plasma beta endorphin, met-enkephalin, and pain intensity in patients with chronic low back pain using TENS or sham TENS. The treatment group received a bi-channel burst modulation TENS through two pairs of self-adhesive electrodes on side-lying position for 30 minutes. Study by Alcima et al. 2022. Compared and studied, the control group received a sham TENS, a pair of the active TENS machine with all parameters set at 0 except the timer. The sham TENS was set to beep at the end of the 30 minutes to mimic the active TENS. Outcome measures: pain intensity, plasma concentrations of beta endorphin and met-enkephalin. 30 minutes burst TENS significantly reduced chronic low back pain intensity immediately at 1 hour and 24 hours after the intervention. The peak analgesia was at 1 hour. Study by Alcima et al. 2022. There was a significant temporal difference in pain intensity between the groups. The TENS group had better pain relief. The relative analgesic effect of TENS started immediately after the intervention, peaked at 1 hour. The p-value is less than 0.001 and won out by 24 hours. No significant difference in beta endorphin and ME between the groups from 0 hour to 24 hours post-interventions, and no significant correlation between the PI and beta endorphin and ME. Can significantly reduce pain intensity up to 24 hours after treatment. Is the study of effectiveness of percutaneous nerve stimulation for chronic low back pain conducted by Jill Moore et al. 2019. It's an original article. Study design is prospective case series to evaluate the effectiveness of percutaneous nerve stimulation using implant for chronic low back pain. Method is percutaneous leads were placed bilaterally to the target the medial branches of the dorsal rami nerves under the image guidance. Percutaneous leads were connected to miniature wearable stimulators for the duration of treatment, 1 month. Pain and disability were assessed long-term up to 12 months after lead removal. The results are reduction in pain and pain intensity in majority of subjects at the end of the treatment. P-value is less than 0.05 and 6 later it became 9 and the confidence interval is 95%. No serious or unanticipated adverse events were reported. Percutaneous nerve stimulation can be used an effective neurostimulation therapy for patients with chronic low back pain. Helps to avoid opioids, denervation, and permanently implanted neurostimulation systems. In relation with the chronic low back pain, I would like to explain a case study from my past experience. A 24-year-old patient suffered with chronic low back pain was taking non-steroid anti-inflammatory medicine. The underlying cause of chronic low back pain was detected as disc prolapse by MRI imaging. She was studying for engineering. Since she cannot walk and stand, by the time she finished her college, she was continuously in bed. She tried all other treatments, non pharmacological, such as traction, decompression. Finally, she came to the orthopedic rehabilitation, and after assessment, her right shoulder elevated, scapula muscles were tight, thoracic spine rotated to right side, overactive right side pelvis rotated internally, chronic pain with a low back. Question: what is most effective treatment do you think is effective for chronic low back pain? In this case, the patient provided with postural correction, gait correction, laser, transcutaneous electrical nerve stimulation, and the osteopath gave the osteopathy manipulation. Within 3 months, she was relieved of the pain. This shows a multidisciplinary treatment will improve chronic low back pain. Another experience of a subject currently interviewed on phone from an orthopedic outpatient clinic with the support of attending physical therapist. Signed and informed consent. Case study is about a 30-year-old IT professional who suffers from chronic low back pain. He is unable to sit for a long time. Electromyography was done. Left pelvis and left knee pain during bending. His doctor prescribed gabapentin, anticonvulsant, and NSAID. He went for osteopathy, manipulation, and physical therapy. Also taking medicine from his neurologist. He described his symptoms as sudden palpitation, and electric shock sensation on pelvis and thoracic area. His ECG was normal. On treadmill test, doctor reported that he has autonomic nervous system disorder. However, he has been gone through a chronic low back pain. The doctor prescribed the gabapentin 300 mg once per day. It is an anticonvulsive used in management of mild seizures, epilepsy in adults and children. Gabapentin was given to the patient for complaint of the burning sensation and pain in the foot, like diabetic neuropathy. This patient was advised to take a drug at night to minimize effects of drowsiness, dizziness, or falls and ataxia. Outcome measured by questionnaire and came to the conclusion, and the treatment he has given was multidisciplinary. Postural correction, IFT, gait training, balance training, McKenzie method, and osteopathy manipulation. Sensory feedback within 3 to 4 months. Conclusion: on the basis of articles reviewed, medicines are important for symptomatic treatment, study design used systematic with reviewed RCT articles. Search engine used Google Scholar, Solar from St. Scholastica, and PubMed. Effectiveness of pharmacological and non-pharmacological interventions demonstrated according to the article review. Non-steroid anti-inflammatory drugs is most beneficial to overweigh adverse effects for long-term management. In conclusion, NSAIDs are effective in treating chronic low back pain. TENS and osteopathy approach as non-pharmacological method found to be more effective. Summary. In chronic low back pain patients, a multidisciplinary logical approach to treatment is more effective. Could include multimodal medical, psychological, and behavioral therapies, lifestyle modification, posture awareness, physical therapy, osteopathy manipulation as interventional approaches improve chronic low back pain.
References. Thank you.